Hi everyone, welcome to today's episode of Aesthetics and Wellness by Dr Yusra. Today I have the amazing gynecologist Dr Shaireen Aleem. She's a surgeon here in Liverpool and she is also available at Dr Yusra Clinic. Today we've talked about intimate health, vaginal health, the changes that occur to the skin and the vagina with aging. We call that vulvovaginal atrophy. The options available for patients for treatment of various different conditions that are associated with perimenopause and menopause. And we've spoken about all the things that you may not traditionally have heard about. So hope you enjoy. Hi everyone, welcome to today's podcast. Today we have Dr. Shaireen Aleem with me on the Aesthetics and Wellness podcast by Dr. Yusra. Dr. Shaireen Aleem is one of the Liverpool's best known consultants. She's a gynecologist. She specializes in menopause and pelvic health, pelvic pain, and also urinary discomfort and issues. You're gonna explain a little bit more, yes, right? Yeah. So Dr. Shaireen is also based at our Liverpool clinic. And Dr. Shaireen, over to you. I know you half like to be known as Dr. Shaireen Aleem, half Miss Shaireen Aleem. And I'm going to explain the difference because a lot of people don't know. When you are a surgeon, as you are,
yes,
you start to use the title Miss. It's a special title in the medical world given only to surgeons. So How would you like us to address you today?
You can call me Shaireen.
Shaireen
absolutely fine.
Yes. Okay, tell us a little bit more about you.
So I'm a gynecologist. Mm-hmm. So I look after mums and women, their health, not just their health during their reproductive ages, but also their health afterwards. Yeah. My specialty is urogynecology, which basically means I look after pelvic floor health, which includes health with regards to prolapse, bladder health, urinary incontinence, as well as other general gynecology problems such as heavy periods, painful periods, basically anything that is associated with gynecology. I have a passion for, and something that I have worked very hard towards over the last 15 years is chronic pain. So we have a specialist clinic in Liverpool where we look after women with chronic pain, which can include pain in the vulva, the vagina, the urethra, lower tummy, and it's something that we've really worked hard on developing and spreading awareness about. And of course, menopause health, which is very thankfully about time widely talked about these days. So not just menopause, but also perimenopause health.
Yeah. Okay. I love that. And you're based both NHS in Ormskirk Hospital and also privately at the Spire and at Dr. Yusra Clinic.
Privately at the Rennickers. At the Rennickers Hospital.
Oh, it was in Spire, sorry. And I got to know you when you first arrived at our clinic to see if we were offering treatments in intimate health, women's health.
Yes.
And at the time, it was something that we were just bringing on. I am very, very conscious of working within my scope of practice. Mm-hmm. And my background is dental surgery and head and neck surgery. And that means I work in and specialize in the head and neck region. I don't work in anything down south. Personally, I call it the VJJ. So I leave all of vaginal women's health over to people who are specialized in that field. Yeah. But I look after a lot of patients who are perimenopausal and menopausal naturally. And so it's a subject that is really dear to my heart. And I have been in aesthetic medicine for over a decade. I've treated tens of thousands of patients, men and women. But naturally, I see a lot of women in our clinic. And over the last decade, I too have aged with my patients. And I have seen them meet their boyfriends. I have seen them get married. I have seen them have their babies. Some of them, I see them as they go through their divorce, and I see them as they start their perimenopause journey. Yeah. And the reason why I became quite passionate about women's health and perimenopause in particular, which is why we're here today, is because particularly, I would say over the last 5 years, I found that I was treating lots of women who were not even aware of what the perimenopause was and didn't think it was relevant to them until they actually went through what we call the change, so to speak.
Absolutely, yes.
The menopause. And the average age of onset of menopause is about 51 in the United Kingdom.
Yes.
And the diagnosis of menopause is a retrospective diagnosis. It's when you haven't had a period for 12 months. And that's what people know to be the menopause. And I think as women in general, obviously you're very educated about it, but the lay woman and the average woman does not know very much about it. We're told a lot about periods. We're told about pregnancy and labor. Then we're completely clueless about how to raise the children that we're given. And then, and we know nothing about the perimenopause and menopause. So, and traditionally, women just had to kind of grin and bear it, work through it, accept that there will be changes. And that's it. And what I used to find is women would come, they would sit in my chair. And the way that I run my clinic is maybe not like the traditional aesthetic clinic, which is one in, one out. It's very much about getting to know the person behind the feature. And that means when they come and they sit down, I ask them what else is going on, what is bothering you, why now? And that comes from a long history of understanding that there is usually a driver, a motivation.
Yeah.
And I'm treating a person. I'm not just treating a feature or a symptom. And what I would find is particularly women in their early 40s, sometimes late 30s, they would come and they would sit in my chair, a little bit cagey.
Yeah.
They were visibly low. They had kind of lost their mojo, lost their zhuzh, lost their confidence. They would kind of not want to look in the mirror. And they would say to me a very predictable, repeated set of symptoms that I came to realize was really, really part of their perimenopause journey. So I would say to them, why now? And they say, oh, you know what? I look in the mirror and I just feel like I've lost my zhuzh. I've lost my mojo. And I say, what else? and they would hold back at first. And the reason why they would hold back is because they felt shame.
Yeah.
They felt alone. They thought that they were the only ones going through these symptoms.
Judged.
Or felt that it judged, apologetic about how they felt. And slowly, I would kind of unpeel the layers, kind of like how you unpeel an onion. And I'm really passionate about creating a safe space in my clinic for patients to talk about anything and everything. Nothing is off the table. And I would ask them what else was going on. And often they would burst into tears, okay? They would tell me that they were feeling low, that they were fighting a lot with their husbands, that they had brain fog. They felt a little bit less relevant at work. They were struggling with sleep. They were starting to notice hair loss, that they started to notice skin aging and their confidence had dropped. Suddenly their jawline is blending into their neck. Yeah. They're putting on weight around their midriff and low mood, really chronically just low mood that they hadn't experienced to this consistent level in the past. And
a very different type of low mood as well, isn't it? The women have actually said that it's low mood, but it's not quite low mood. And I'm not quite sure what it is. What is it? So,
exactly. It's a very lonely low mood as well. It's very lonely because they feel they don't understand themselves. So how can how can they express to others? So I used to see this consistently in my clinic. I used to see this with the 9 o'clock patient, then the 10 o'clock patient, then the 11 o'clock patient throughout the day. And by the end of the day, I'm thinking, God, all of these women feel alone, feel abnormal, don't understand what they're going through. And they've gone to their GP. And for all the love I have a lot of love for my GP friends, but they would be given antidepressants and told, here you go, take this and crack on, love. And whilst, yes, perimenopause can result in depression and anxiety, and on the National Institute of Clinical Excellence, one of the guidelines states that antidepressants are a treatment for this. To me, it is not the first line measure. And actually, often patients need to have, they have a hormonal imbalance. So we need to talk about hormonal replacement or hormone balancing. And we would have a chat with them about this because they're 40, right? They've just come out of their 30s or their late 30s. They don't think menopause is relevant to them at this stage. They're still getting
young at heart. You're young. Yeah.
Exactly. So they haven't connected the dots. And what women don't realize is actually the symptoms of perimenopause can start 10 years before the onset of menopause. And hormonal changes, and we now know this, and this is scientifically proven, is that the hormones start to reduce quite significantly from the age of 35.
Yes.
Right? And actually, my pregnancy, you were involved in my last pregnancy and were kind of instrumental from afar at helping with the delivery of my last baby. I was 35 when I was pregnant. I didn't even know that they call it geriatric pregnancy, right? Which I now know that term has changed. What do they call it now?
Well,
we still
that's
call
a horrible
it's
word
a horrible
to use.
statement, isn't it?
It's a terrible word to use. We don't use terminology like that, but what we have is we have certain guidelines that we would follow, and it is usually after the age of 39, 40 where we would have slightly different guidance, but we wouldn't label it as something.
But traditionally, that label existed.
And that was a terrible label, I think.
It was a terrible label. I mean, when I found out, I was mortified. But there is a reason. And I think what we're seeing now more and more is women are having children much later in their years.
It's very, very much later, yeah.
I also think women have been lied to. I think career women in particular were told, don't worry about it, have babies later. You can have babies at any time. Prioritize your career, thinking that they will forever be able to have babies. And the reality, whether we like it or not,
Absolutely,
the reality is every single time we are ovulating, we are losing an egg. And we are edging closer to becoming depleted in our egg reserve and therefore less likely to fall pregnant as we age. And I see a lot of women in their early 40s now going through IVF saying, I wish I knew. Had I known, I would have taken action sooner, whether that's egg freezing or whatever else. Had they known, had they been empowered with the information. And that's the crux, that's the word that I'm really after, is empowerment. I'm not sugarcoating. I do not sugarcoat anything. I'm a very, very straightforward, honest practitioner. These are the facts.
And you can decide.
Exactly. Do with it as you will. And I always say this to everyone that I meet. First of all, do not fear having children. But second of all, you may choose not to have children, and do not fear it, because you do not start or end as a mother. When you become a mother, that is not where you begin in relevance, nor is it where you end in relevance.
Absolutely.
So whether or not you have children is such a personal decision, but it's important to understand the trajectory and the normal biology. Part of that is childbearing, part of that is the perimenopausal changes, and part of that is the hormonal changes. And with those hormonal changes come a set of symptoms. And traditionally, again, because of, the news and social media and all of these movies that we've watched growing up, people think of menopause as hot flushes. So when you have hot flushes, right? When you become, and there's a fear around that. There's a fear of becoming irrelevant and not relevant in the workplace. And so unless women are going through hot flushes, they kind of don't join the dots or realize that they might be in the perimenopause or they might have a hormonal imbalance. And that is something that I found in my clinic a lot. And so based off that, I used to see women all the time sitting in my chair, literally crying. And they say, I just want to get my confidence back. And so I thought, first and foremost, you're not abnormal. You're not alone. Every single woman is going through this. Nobody escapes it. The queen has gone through the menopause. The next queen will go through the menopause. It is a normal part of aging. And with that, yes, you will have a hormone depletion and there will be a set of symptoms. And hot flushes are just one of them. And they are often the late stages. The beginning, patients start to feel anxiety, overwhelm at work.
Not quite themselves.
Losing their words, cognitive dysfunction a little bit, memory loss, not sleeping well, irritability towards their children, wanting to kill their partners. Very common. Pretty much 99% of women that I saw would say, yeah, I want to kill him. And even if they have this irrational rage, they know that it's an irrational rage. They can't control it. They still feel it. They still express it. And then they don't understand why they're going through it. Their husbands don't understand why they're going through it and think, what is wrong with her? And actually, I thought, wouldn't it be great if both man and woman understood that this is normal?
Yeah.
Okay. This happens to everyone. The woman next door is going through it as well.
Yeah.
You've not got the short change or the short end of the straw.
Every woman is going to go through it.
Every woman is going to go through this. And if we talked about hormone balancing and also normalized seeking care, normalized access to care, normalized the low confidence that actually drive patients into clinic. And so I did a big report. It's called Glowing the Distance Menopause Skin Report. It's available to download free of charge for patients on the website, www.dryusra.com. And I think it's such a good guide and tool. And so we surveyed over 2,000 women in the UK. This was about a year and a half ago, and we published it last October. 2,000 is a huge database of patients.
It is indeed, yeah.
And we asked them a whole range of different questions about their experience with the perimenopause and menopause. And we surveyed women who had gone through premature menopause. So some people go through premature menopause at the age of 18.
Absolutely,
we had a couple of patients who had that. People who were perimenopausal, menopausal, and postmenopausal. And we asked them a whole range of questions about symptoms. We asked them how skin aging made them feel. And what we found was 63% had no idea about perimenopause. They didn't even know that term existed. They were afraid. They were afraid of feeling less relevant. They were afraid of losing their femininity. That's really quite scary for a woman because your femininity is almost your superpower as well.
It is, yes.
And it's your identity, right? So women were terrified and in denial. They didn't want to know. And they thought, oh, I really don't want to go through that. Maybe I'm not going to go through that. We all have these thoughts. And actually, they saw it as almost the beginning of the end.
Yes. Right? And I'm going to become this hot, sweaty person and it's all downhill from there.
Exactly. And my husband's not going to want me anymore.
Yeah.
I'm not going to be relevant
What
at
else
work.
is going to happen?
Exactly. and at work is someone younger going to come and replace me? And actually, do you know how much superpower these women in their later ages or in their 40s, 50s have? They have a wealth of experience that make them absolutely phenomenal at their jobs. They just need to have their hormones boosted, because if you feel low confidence, you essentially, if you lose the bounce in your step, you don't show up as your best self. You don't communicate and hold eye contact. And that's what I was finding. Women didn't want to look in the mirror. They didn't want to have eye contact because they had lost their confidence. And when we looked at confidence in particular, we found that the pursuit of confidence was the main reason why patients wanted to seek aesthetic treatments. The number one reason why they wanted to seek aesthetic treatments was because of sagginess in the jawline. So again, like newsflash to every woman, that will happen. Your jawline will start to sag. That is a normal biological process. And there are things that they can do about it. And the impacts were huge. And I'm talking about 68% of patients said that they lost confidence. 48% of patients didn't want to be in photos with their family. They didn't want to go out. They were hibernating. They refused to socialize. About 50% of patients admitted that they were in low mood, felt loss of confidence and anxiety. So we're talking about serious psychosocial impacts that is secondary to skin aging. And we cannot dismiss the skin-psyche connection. We cannot dismiss, it's not about vanity. When patients come and see me, I am really, really passionate about breaking the stigma, because when they come in, they often say, I feel really vain, or I don't want anyone to know, because there's a stigma associated with seeking treatment, right? And they feel shame about it. And actually, we know when you look good, you feel good. And when you feel good, you carry yourself differently. You have a power in yourself and how you carry yourself in your relationships, whether that is personal or professional.
It just changes your entire personality. It makes a big difference.
Absolutely. And I see that when I do the skin changes, when I do the aesthetic treatment, they come back with a sparkle in their eye that they didn't have before. They've got their mojo back. They're carrying themselves differently. Their shoulders are up. They're looking me in the eye. It's a whole different game now. And part of that is also discussing lifestyle treatments and hormone balancing. But what I also found over the years is women are starting to become more and more aware that actually your skin changes not just on the face, but everywhere, including down below. And so they are seeking treatments for vaginal changes, for intimate health, and they're experiencing difficulties. The number of women I see with pelvic pain, the number of women I see who are saying that they've got dryness down below, or discomfort. Or loss of libido. It's huge. And again, it impacts them psychosocially, but it's not talked about. It's still taboo. It's still stigma. And they don't know where they can go. They don't know where they can go for prolapse. They don't know where they can go for all of these things. So that's where you come in. And I'd love to hear kind of your experience and your thoughts about that.
So, everything, I can resonate with everything that you've said. And again, it all comes down to giving time to that lady. You said patients or, your lovely women, they come to your clinic and it's not in and out. And you sit down and you try and understand why they want this treatment. What is it really affecting? And that's what I've always advocated. I've been working in the NHS for over 20 years. I've been a gynecologist, a consultant for over 12 years now. And this is what I've always said, that this is not just science. It's also an art form. And you can be a doctor and you can say, right, this is your condition and here you go, this is your medication. But to try and understand, what is this condition? How is it affecting you? What else could be related to this is an art form. And some people can do it and some can't. And I've learned that over the last 15 years, especially with my pain clinic, that you have to individualize the person. You have to sit with them and give them time and literally listen to them. Just be quiet and listen to them. And then you start unraveling the whole situation. You start unpicking all the different symptoms and then you start connecting the dots. I think that is the most important thing. And that's why I feel that when you talk about menopause, yes, the women will come and they'll talk to you about some typical symptoms where, unfortunately, vast majority of women will contact you if they have the typical symptoms, which is hot flashes or night sweats. But when you start talking to them and you develop that rapport between yourself and the lady, And you just start having a lighthearted conversation. Said, okay, what else? How are you affected? How are the kids doing? Do you have parents that you have to look after? Because there's another thing that we forget, that at that time, in that particular age group, whether it is your end of your third decade or you're in your fourth or fifth decade, a lot of other things are happening as well. Not just your body is changing because of the changes in your hormones. Your children are growing up. They're becoming these very young teenagers who are not easy to manage. And I can tell you that from personal experience. But also your parents are getting older.
Yeah.
Plus you're becoming more senior. If you work, you're becoming more senior at your workplace. So there's more pressure on you. There's more expected of you.
Yeah, of course.
And in some cases, people have been working at one place for a very long time and they don't want to be that. They don't want to do that work. And then to top it all up, you start looking different. You know, you could eat something, have a healthy dinner, you don't gain any weight. And now even if you look at the dinner and you gain weight. So all these things have a compound effect on the lady. So it all comes down to sit and talk to her, try and understand what she's going through. And as part of that discussion, I always talk about intimate health. It is something, if there is one thing that I can achieve, when I retire during my career, is the awareness, not just, in the women, in the ladies that we see, but also in the clinicians, and not just gynecologists, the GPs, the urologists, the surgeons, the aesthetic doctors like yourself, you're already very well aware, is to be aware that this is a problem and you should ask the right questions. And sometimes the questions have to be asked in a very sensitive and sometimes in a very light-hearted manner. You don't want to say, so do you have painful intercourse? Are you struggling? That's not the way you should ask it.
It's a delicate conversation.
It's a very delicate conversation. And again, when you talk about intimate health, so like you said, there's changes to the skin. Our entire body is skin. And we forget one of the very large areas of skin is the vulva down below. The skin of the vulva, the skin of the vagina. And these areas...
Can we talk about that? So what is the difference between the vagina and vulva? So like when we're talking about... You're talking about...
we spoke about that the other day, didn't we?
But for all of our listeners, our patients don't know, right? So we want to talk... And what you're talking also about is communication, the arts of communication, so to speak. How are we communicating with our patients about this? These are opening up these delicate conversations.
And your question is fantastic. It is just a prime example of the fact that how I can just, not realize and just assume that, the person knows about the difference between the vulva and the vagina. So the skin on the outside that we see, that our eyes can see, is the vulva. So you have the vulva, which is the area below your bikini line from the front and goes down to the area of your buttock. Okay. And then the area that is surrounded by the vulva, the vulva is basically almost framed by, is your labia, which is the thinner lips. And then inside, further down from the labia, you have the vaginal orifice and the vaginal canal itself, which is also lined by the skin. And the one thing that we need to realize is that when we talk about the vulva and the vagina, they don't function in isolation. They are sitting very close to other organs. For example, when you talk about the vagina, anything that affects the vagina is not going to affect the vagina alone, but it'll affect the urethra, which is your water pipe, your bladder, which is sitting very intimately next to the front wall of the vagina, and even your bowel, which is sitting right close to the back wall of the vagina. The opening of your back passage, which is your sphincter. And then, of course, at the top end of the vagina, you've got your uterus, your cervix. And there are multiple organs that are sitting very close to this area. And then again, having that conversation with your ladies and say, right, okay, the symptom is in the vagina, but what about your bowels? What about your womb? What about your cervix? What about your bladder? How those? Because it could be that the symptoms and the problem is actually there, but the pain and the discomfort or whatever symptom you're getting is actually in the vagina. So I think one message that I always give to our ladies is that this is all connected. It doesn't function in isolation. And that's how it's been from the very beginning, when we were babies inside our mom's tummies. And you will remember reading all the embryology, that the embryological ridge from which these organs develop actually is the same ridge, same receptors, same, it all originates from the same tissue.
Oh yeah. I mean, I'm a big believer in holistic health and the connection. I talk about the mind-body connection a lot.
Absolutely.
And also holistic health. And that means, I talk about the oral microbiome, the skin microbiome, being all parts of the digestive tract, all the way down to your bowels. We're talking about gut health. Everything is connected. The more we realize this, the more we start to treat patients as a whole, rather than
a whole, absolutely, a holistic approach. And that's where I think gynecology needs to change and evolve, and it already is. There are some fantastic gynecologists, some fantastic men and women who are doing really good work where the approach is definitely more holistic. So it's not about just sitting there and saying, right, this is a vaginal problem, here you go, no further conversation. So, people, ladies who will come to our clinic, like yourself, I'm always giving lots of time to my women, and as a result my clinics are very late.
Yes,
so I'm not saying your clinic is late, you're much better than me.
No, I would say that, I saw a funny meme the other day on Instagram. I sent it to my girl Sophie, my front of house, and they were talking about how in practices, those practitioners who talk a lot, and I'm one of those. I talk a lot with my patients. I listen.
You have to. You
absolutely have to. And I started off my journey into aesthetic medicine kind of as a patient as well. When I was a dental student, I became very unwell. And during that period, I saw so many doctors. And really, the one doctor that set the tone apart and was instrumental in my pathway of healing, my journey of healing, was a doctor who did nothing, prescribed nothing, but gave me hope and gave me time.
Absolutely.
And that in itself was healing. He listened to everything and he started to connect the dots. And I talk about this a lot. And I say, listen, you cannot treat body without mind, nor can you treat mind without body. Everything is connected. and I think people are understanding that more. And that is one of the things I think that has gone wrong slightly with traditional hyper-specialized medicine. Although, yes, we are special. I'm a specialist in this area. You're a specialist in
and it's very valuable. That medicine is very valuable.
Absolutely.
But
we need to know how to connect the dots. And we need to understand that one thing will impact the other. And there is an impact no matter what you do. And you talked about this so beautifully. But for the face, for example, when I'm treating the chin and I'm aware that a patient has a weak chin, they often also hold tension in their jaw. Everything is connected. Remember back in the day when we had these nursery rhymes of your head bone's connected to your neck bone and your neck bone's connected to your shoulder bone. Everything's connected, right? And so down below, everything is connected. And I think also the skin is a continuum. You're talking about skin-related changes. The skin on the face changes as patients age. We know from the hormonal changes that they have, estrogen reduction,
the reduction,
progesterone reduction,
testosterone reduction.
Right? So testosterone is a female hormone too.
Yeah.
And we know that it reduces by approximately 1% every year from the age of 35. That results in loss of libido. Patients might experience acne. They may also experience dry skin, not just on the face, but remember the skin is as a whole organ. It's actually the largest organ of the body. And so it's your vagina, your vulva, right?
Vulva and your vagina.
So the whole thing, that is skin. And and we know that the skin, when you have a reduction in estrogen, you lose collagen. You lose approximately 1.5% of your collagen year on year, actually from the age of 25. Okay.
Yeah.
When you hit 40, between the age of 40 to 50, you lose 30% of your collagen. So suddenly you go
everywhere.
Everywhere.
Exactly. And we don't talk about
We don't talk about it.
How many women do we tell that, you are going to lose collagen down below? Your blood supply, so your estrogen levels are going down. The blood supply to the skin is going down. The collagen is going down. All of this is going down. So the nutrients that are supposed to be supplied to that area, the vagina, the urethra, the bladder, it's not going to happen.
OMG. So that's really scary. So yeah, I think, a lot of women know, they now know. We've educated them very well about skin-related changes of the face. Okay? We've told them that they're going to lose collagen. We've talked about regenerative medicine. We've explained to them that we can use treatments to help stimulate new collagen and that they will go through a rapid breakdown of collagen from the age of 40 to 50. It happens very quickly, which is why I see so many women of that age group. They come in at around 40 to 50 because they notice the changes. They might have got away with it up until 40 and then suddenly they're like, oh, I'm not getting away with this anymore. The skin around their eyes, which is 1/10 the thickness as the rest of the face, thins very rapidly. So you start to see all of these discrepancies, pigmentation, orbital fat prolapse, all of this you start to see. And that drives them into the clinic. But what they don't openly talk about and what they are not aware that they can even access treatments is for skin-related changes down below.
And the treatments are so simple and so incredibly safe. And they are so, they make such a massive difference. It's not a small difference. It's a huge difference that it makes to the woman's functional life, her psychological life, her life in general. And then, again, talking about changes, all the changes that you've mentioned. You'll remember when we were students, we used to use the word atrophy.
Yes, absolutely.
And, I'm sure,
Shrinking
not
back,
that in dentistry they might
yeah.
have not mentioned this, but definitely in medicine and especially in gynae, you remember the word they used to use as vulvovaginal atrophy, which basically literally means the withering away of skin.
Yeah. We talk about lipoatrophy in the face, which is fat loss. So any atrophy basically means breakdown of tissue or reduction in tissue. And, so down below that happens, You get shrinkage of what? Yes. What happened? Let's talk detail. What happens exactly?
So basically, as you said, your hormone levels start reducing from the age of 35 onwards, and every woman is different. Every single woman on this planet is different. Some will experience quite a rapid reduction in their hormones. Some will experience a very haphazard up and down of the hormones. Some will respond well to the reduction of hormones and are okay. And that is still quite a large number of women. They're fine. They can manage the reduction in the hormones, but some don't. So when you have these basic hormones reducing, those hormones have a function in your body for all those years, 30 years, 40 years, 45 years. Suddenly your body doesn't have that. So it's like you're used to drinking water, and suddenly your water supply is reduced.
Yeah.
So what's going to happen to the skin? So as your estrogen and your testosterone levels are going down, all those tissues that need that are affected. So coming back to the fact that your collagen content is reduced, your thickness of the muscle is reduced, your lipid content is reduced, and most importantly, the blood supply to that area gets affected. And when the blood supply is no good, then the nutrients that are supposed to go to the skin, they get reduced as well. So how does that affect you? It can be a large variety of symptoms. Some ladies will, in fact, I would say quite a fair majority of ladies will come and say, I'm not quite sure. It doesn't quite feel right down there, but I don't know. It's not dry, but I'm not quite sure what it is. And you'll be surprised, a lot of women actually will come and say to you, I would say the larger proportion of ladies that come to me actually don't complain of dryness. They just don't feel right. So the words they'll use is things like feels a bit heavy, doesn't feel the same. There's a throbbing, there's discomfort.
Throbbing all the time or during intimacy?
It can be at any time. Some will say, I sit there and I'm always aware of something is happening down there. So, and of course, some of the ladies will say that intercourse is just not the same. And this is another thing that probably we need to do a different podcast on. And that is, they almost accept it. As they're getting older, well, the frequency of intercourse is reduced. It's part of growing up, but it isn't necessarily part of growing up or getting older. I don't like using the word older. I'm going to say part of growing up.
Okay.
So, one of the typical symptoms, some doctors will say, well, are you having any difficulty with intercourse or do you have any dryness? And if the lady says no, then they might say, well, maybe, it's not menopause. And that's where I think the mindset has to change. You may not get presentation of ladies saying, I have dryness and it hurts with intercourse. They may not have that at all. Yes, I can manage intercourse, but it doesn't feel right. Then again, the other symptoms associated with them are the organs that are, the cousins that are right next to the vagina, the bladder and the bowel that are sitting there. So some women may not have any vaginal symptoms at all, but all they have is urinary frequency, urgency, have to rush to the loo, have these cystitis-like symptoms, but every time they go to the GP, their urine is checked, there's no infection, that's fine, just go and drink some water, you'll be okay.
So when you say cystitis-type symptoms, are you talking about burning when they're peeing or pain when they're peeing or frequency?
I love that question. So if anybody comes to me, I have cystitis-like symptoms, I always say, right, okay, let's talk about what is cystitis to you.
Yeah.
What is cystitis to you? Because every lady's understanding and experience of cystitis symptoms is different.
Yeah.
And I would, again, tell my juniors as well, the doctors who train with me and also my colleagues that don't just take it a given that cystitis is those typical symptoms that you've read in your book. So,
I love that you say that because I don't believe that there is anything that is typical about, we're all individual. And whilst there are 35 documented, there's now more coming out.
Typical symptoms
of menopause. Some patients may present with all. Some patients may present with one. Some patients will not even verbalize which ones they're going through. I hear patients go, I never had anything. Fine. But everyone is different. So patients may present with a wide range of symptoms or not.
Symptoms. So let's talk about some typical ones. They will say that, I can't quite hold on. I feel like I need to go to the loo all the time. And if I'm not going to the loo, I'm aware that I might need to go to the loo. Some ladies will say when I pass water, it burns as I'm passing water, or it burns when the water touches the skin. Some ladies may actually have urinary tract infections. That is another symptom of menopause, where they will get actual urinary tract infections, because we know when there is a reduction in estrogen, the lady is more vulnerable to bacterial infection. Again, estrogen is protective. It is anti-inflammatory. It helps. So that can happen. And the skin thins, the blood supply thins. That protection is gone.
Yeah, I mean, this is one of the other things that people don't realize, is there is a function for your for your JJ, for your vagina, and it's a gate, right? So when we talk about lips or the labia majora and minor, they are a gate, and they stop bacteria from entering.
Yeah.
And as we get vulvovaginal atrophy or thinning, you get shrinkage, visible aesthetic shrinkage, particularly of the outer lips.
Yeah.
And so what will happen is, and this is something that I'm learning about as well, is when the outer lips shrink back, the inner lips sometimes have to grow, and they grow longer.
And they look different.
They look different. They're trying to gatekeep again. They're trying to keep that gate. So patients, for me, aesthetically, they say to me, it looks different. It looks, and although their partners might not be bothered, they're bothered. They're losing their confidence then. They don't want to be intimate, or they don't want to be intimate in lights, So these are little things that I think we do need to talk about. And another function of collagen, people talk about collagen, we lose collagen. Some people go, oh yeah, whatever, it's part of aging. Sure, I got that, and we can all age in different ways. Some people might want to have a little bit of help along the way. Some patients might just wish to age without any help. That's fine, and to each their own. But people need to understand that the skin is not just there as an aesthetic.
It's not just the looks.
No, it's the skin health.
It's got a function.
It's got a function. So the skin, and collagen has a function.
Yeah.
Collagen is not just there for structure and integrity. It's not just there to keep everything in place. It's actually important from a cellular level. When we are aging, if we're looking at the pathophysiology of aging, and we know from scientific evidence that we will get a reduction in type 1, type 3, and type 7 collagen, okay? What will end up happening is that impairs wound healing. Collagen is there for cellular differentiation. It's there for wound healing. It's there for cell signaling. So there are other very important functions of collagen, and that cellular change results in a cutaneous manifestation, i.e., the skin looks different, but also its function changes. It isn't able to keep the bad things out anymore or the good things in. The barrier function becomes impaired. I see this in the face. My patients who are postmenopausal, their barrier is compromised. They're dry, they're irritated, they're getting rosacea, inflammation on their skin, and we need to work on improving barrier. So we call that corneotherapy. The same down below. Sorry.
No, that's really fantastic what you're talking about with regards to the barrier, because I have seen in my clinical experience that women, there's a skin condition called Lichen sclerosis of the vulva, which you'll be aware, is almost like getting eczema or dermatitis of the skin. And these ladies are fine, and they manage that condition fine for years, and in some cases for decades. But there is that particular time in their life where they're experiencing perimenopause, and especially menopausal symptoms, that when there is that decline in the estrogen, suddenly this lichen sclerosis is so hard to manage. Those medications are not working anymore. And what you've just said makes such good sense. And that's why I always say that one speciality cannot treat a lady. Sometimes you need that MDT. Interaction. What I've heard from you today is definitely increased my knowledge about skin barrier. And straight away I'm thinking, I've actually experienced that. I've seen that in ladies, and it has happened. Yeah. And it's happened down below.
It makes sense. I'm telling you, everything. So, aging that we see on the outside starts on a cellular process. So that's how my brain is wired to always think, okay, what's happening right down at the granular cellular level? And so I learned so much from you. I'm glad I'm teaching you something too.
Yeah. No, it's so important just to have that holistic approach, that understanding of the problem is really crucial, because a lot of these ladies, again, fully understandable, that are frightened that there must be something seriously wrong.
Yeah. I am hearing about all these changes. I'm not afraid about facial aging because I have all the tools in my toolkit. I can go in, and I'm not afraid of weight gain around my abdomen because I have cool sculpting in the clinic. I have emerald laser, I have M-Sculpt Neo. I've got the tools that I need.
Yeah.
I've got the biostimulators for my face, so I'm okay. I am afraid of changes down below because for me, that thankfully I'm not quite there yet, but that's coming. It's coming to all of us. So it's good to be empowered with knowledge. So you're not walking into it being unaware, and also not knowing that you can access care and thinking it's an inevitability. There's nothing I can do about it, and knowing that there are actually options is very reassuring, I think.
Absolutely. And also giving the lady that assurance that it's not sinister. I think one of the things I face, especially in my clinic, is that, is this serious? Could this be cancer? Is there something wrong with the cervix? Because there is that lack of understanding. And that's where, again, we come back to the same thing, giving her time and talking and explaining to her that this is why this is happening. And they go like, right, okay. And I think taking that first thing, giving them that reassurance that this is not sinister, and then, right, what are we going to do about it now? Yeah. And that other barrier is also quite significant, which is the use of hormones. So, for example, when you have these changes within the skin of the vulva or the vagina, one very common, easily available, very, very safe treatment is to use topical estrogens. Now, down below. And you can use topical estrogens in the form of little tablets or pessaries that you can put in the vagina, or in the form of creams. And I think historically, people have always been very worried and have used it very sparingly. And it's because the knowledge around the estrogens, and especially the safety profile, was not as good as it has been over the last many, many years. But unfortunately, what I still find is that, clinicians who look after their ladies, they do a fantastic job, but sometimes, don't have the confidence or the knowledge or the experience of saying, look, I think you can use this longer. I think you need to stay on it, or I think you can increase the dose of it and you'll be safe, you'll be fine.
There's a lot of fear around hormonal replacement therapy.
Huge,
and I think we need to talk about that because that fear came from the study that was done over a decade ago.
WHI, the Women's Health Initiative, yes.
And it was released early to the media, who, of course, bad news makes news, right? And they ran with a headline that wasn't quite put into context. And the headline was HRT causes breast cancer. Yeah. And I know that, my mom's generation, for example, took all their HRT and flushed it down the toilet because who wanted breast cancer? And now breast cancer is on the rise. So it's something that we are all very wary of and all very aware of. And that is still a fear of women. They are still coming in saying, I'm avoiding it because of this. Yeah. And so they'd rather grin and bear the side effects or the symptoms of menopause without accessing HRT in all its forms because of that fear. Now, we need to put that into context, because actually, if you put it into context, yes, there is a slight elevated risk. But can you tell us a little bit more about that study and your your experience, expertise about HRT and breast cancer?
So I think the most important thing is that whenever you treat anybody with any medication, there will always be a side effect. There is nothing that is 100% safe. You need to look at the risk. How is it high? Is it low?
So even paracetamol. If you look at the back of a paracetamol,
I think that has,
scary.
That has more side effects than actually topical estrogen. I can confidently say that. Yeah. So I would say the first thing we've always got to look at is the level of harm that you could get from the treatment, and also be aware and have the knowledge of the latest research and evidence that supports whether it is low harm or high harm. The second thing, which I think is even more important, is why does that person need it? I've always said this to people, that if you're going to operate on somebody, you can unfortunately get complications from surgery. We all know that. The problem is not that. The problem is, did this person need the surgery? Yeah. That is the most important question. So on the same lines, I would say there are risks from HRT. The risks are very, very minimal. HRT has become, over years, extremely safe. But the second question we need to ask ourselves is, does that lady need it? And if she needs it, what are the risks and benefits to her? And I know that in some cases, women who have been diagnosed with breast cancer and are being treated for breast cancer, their risk of stopping HRT even during cancer treatment was so high and so detrimental to them that they stayed on them. So it's not an easy conversation. It's not a straightforward conversation. It's a conversation that, needs to take into account many, many aspects. But I would say these are the two most important aspects that need to be taken into account. So I have ladies, for example, one very common group of ladies that comes to me is, of course, ladies who experience pain and discomfort down below or any other symptoms, but have had breast cancer.
Yeah.
And they will actually usually come and see me and say, look, I know I can't take estrogen because I have had breast cancer. And I would actually listen to them, and I would listen to what their concerns are with regards to taking topical estrogen. But
and does topical estrogen, sorry to cut you off there.
No, it's okay.
Does topical estrogen, because look, a lot of people again think HRT is a tablet. They don't understand that there are a range of different ways that we can rebalance their hormones. That might be an oral HRT, which was the traditional. Now we have patches, and we have gels. We have estrogen gel, and we have testosterone gel.
Yes.
And they can also have the merino quilt. So there's a whole different range of options available to patients.
Yes.
And from my understanding, and please correct me if I'm wrong, but the topicals have a lower risk of these of breast cancer as compared to the oral.
Yes. So anything that goes through your skin bypasses your first pass metabolism. So it goes directly into your blood. So the advantages are that it's safer, so less likely to give you side effects. It is safer because it's less likely to give you blood clots, which is one of the very big concerns with the traditional HRT. And, when you talk about side effects, that includes risks of breast cancer and all other sort of list of things that comes with it. So anything that is being applied on your skin, whether that is a patch or a gel, is considered to be safer. The other, so you've got HRT that is systemic. So you give it to the ladies for symptoms such as hot flashes, night sweats, tiredness, brain fog, not feeling quite right, low mood. But then there is topical HRT or topical estrogen that you actually give to the vagina. So the lady's supposed to insert it into the vagina.
And what will that do?
So that will help you with your vaginal health. That will help you with your intimate health. That will help you with the symptoms of the menopause. So there is a terminology for it now. In fact, we should have maybe used that terminology from the very start, and it's called genitourinary syndrome of the menopause. Long terminology. It's a bit of a mouthful, but basically it encompasses all those changes that take place in your intimate areas, including your vulva, vagina, bladder, and bowel. And actually talks about those as well, not just hot flashes and night sweats. So traditionally, people would go to their doctors and they'd say, well, I'm getting some urinary symptoms. I get cystitis-like symptoms. Oh, sorry, I've moved. And, they would be told that, no, you don't have any hot flashes or night sweats. They're not typical symptoms, so you can't have HRT. But now we know actually they do need vaginal HRT or estrogen. So that is also topical. And so the only way to give it is topical. It works in conjunction with the systemic, and it works better than the systemic for the vaginal symptoms.
Does that increase collagen production?
It helps with the entire health, just like the face. Exactly like the faces that you fantastically deal with. It helps with the thin, it makes it thicker
skin.
It makes it more moist. It makes it more, it's more pink. It's more stretchy. And it helps with the pH. It helps with lots of things.
It's really interesting because now we are actually looking at estrogen creams for the face. But they have to be used with care. But it's certainly an emerging part of aesthetic medicine. I think, aesthetic medicine is rapidly evolving all the time. But we know we lose estrogen, and estrogen is vital for skin health. So there's a lot of emerging data about that. And I have seen the difference in patients who have accessed care, testosterone gel, estrogen gel. They get their mojo back. They come in with a sparkle in their eye again, whereas before they were feeling low. Low libido, that's a big thing as well, I think.
Yes.
And then lubrication. A lot of women ask about how to manage that. What would your advice be? Do you tell them to use lubricant or not?
So I'd always do a thorough consultation. I would do a in-depth examination. I need to make sure everything else is okay down below. I think those are the two main things I would do first. And usually the way we start the treatment is to use topical estrogens. And I will get ladies, most of our ladies will have a massive benefit and a huge difference just after topical estrogens. And I would usually advise them to stay on it, because when they stop it, then their symptoms can come back. In some cases, the estrogens alone may not work, or they may not work at all. Then you can also use treatments such as DHEA, which is a compound that can be converted into estrogen and testosterone, because our body is producing both of them. So that helps as well. Now,
is that as a gel?
That's as a pessary as well. It's called prasterone. That can also be used. For quite a fair amount of my ladies, they will say, well, while I'm using the estrogen or the DHA, I feel great. But in between, I just wish there was something else I could use. So in those cases, I will suggest some personal lubricants, and I like lubricants that are more in line and more holistic, more natural. So there is one lubricant that I use. It's called Yes, which is organic. It's oat-based, and it's less irritant to a skin that is already quite sensitive.
This is for women to use during intimacy.
During intimacy, but also outside intimacy. Some ladies might be just sitting and reading a book, and they just don't feel quite right down below. So I'd say, right, fine, it doesn't need to be used just with intimacy. There are some very nice vaginal gels that we use as well that can be inserted in the vagina. And just to give you comfort, what happens if your face is dry? What happens if your hands are dry? We just reach out for our best pot of cream and apply it. So why can't we do that down below, as long as it's safe and doesn't cause any harm? What is wrong with doing that?
Yes, I love that. Wow, amazing. Well, I'm conscious that we're running out of time, and there's so much more that we can talk about. So I feel like there's a second podcast in the making. And I think next time, you're a surgeon, and we've talked today about, really, I think this is something that I relate to, and I think every single dentist and surgeon will, which is our love for what we do. Our passion comes from a combination of looking after people, the scientific background of what we do, the love for science, but also the artistic changes, the art. So it's that combination, art, science, and people, is something that I hear from so many people that are in this field, surgical, dental. I know you and I share this, and we've had this chat before.
I would have been an artist if I wasn't a surgeon. I think I would have been.
I always say the same thing. I actually used to paint. I just don't have the time to do that as much. Now I paint with filler now. That's why
it is art. What you do is art with science.
Yes. Thank you so much for joining.
Thank you for having me.
Such a pleasure to have you.
It's been an absolutely fantastic experience. Loved every minute of it.
Oh, thank you. Hopefully we'll have you back on again.
Hopefully. Thank you.
Thank you.